Awesome. Hi, everyone. Thank you for joining us today for the very first episode of our Pearl's monthly lecture series of 2025. For anyone who is new here, Pearl stands for Focus for Emergency and Acute Care in Resource-Limited Settings, and we're a non-profit organization entirely run by volunteers. And our aim is to provide free POCUS training to doctors around the world. And it's my great pleasure today to have Dr. Cornelia Kilalang, the Chief Pediatrician working at Port Moresby General Hospital in Papua New Guinea. And today she's going to present on the topic of POCUS in pediatrics. And at the end of the presentation, you will have the opportunity to ask Cornelia plenty of questions. So Dr. Cornelia, please take it away. Thank you.
Thank you, Long, for the introduction. And hi, everyone, and welcome to the first Pearl's lecture series. So we'll be looking at POCUS in pediatrics in Papua New Guinea. So let's make a start. So the outline of this afternoon's session is we'll give a brief overview of where we are and pediatric POCUS in screening in country, the windows that we use for pediatric echo, and we'll go through some common or echo findings of some common cases that we see, and then summary at the end. So Papua New Guinea is an island nation in the Western Pacific region, north of Australia. We share the same land border with Indonesia. There's about an estimated population of about just over 10 million people, 22 provinces with 800 different languages. Currently, there are about 40 clinical pediatricians practicing, 2 of which are focal pediatricians in pediatric cardiology, and these are the ones that are able to do pediatric echo. Echo is done at the National Referral Research and Teaching Hospital, where the focal pediatricians are, and the kids in the provinces, they happen to have their echoes done early if you're able to travel out to the provinces. The provincial cardiac screening that we do in country is supported by partners, and that's organized by Operation Open Heart Foundation, which is a local non-profit organization that supports the team's work with cardiac screening, training, purchase of equipment, and organizing open heart surgery with the Open Heart International team and the local team. The provincial pediatricians have their cardiac registers and they organize patients for screening. The wait is long to have that planned echo, and so this event is an event that carers, parents, and pediatric teams in the provinces look forward to, as heart diagnosis can finally be made or excluded. So last year we were able to do 15 screening in 15 hospitals, and just over 1,000 children were screened. 16% of those children screened had rheumatic heart disease, but that may be an underestimate. The common cases that are seen during the screening, pericardial effusion, also in tamponade in a lot of children, rheumatic heart disease with the common lesion being mitral regurgitation and stenosis, or aortic regurgitation with mitral valve lesions, or a combination of all, and so as congenital heart diseases. Outcomes of these children screen. So there's a good number of children that are referred for screening that have normal study, and so they're discharged, and this is a big relief for parents that would normally have been given a diagnosis of a heart lesion for their child. And pericardial effusion in tamponade is also a common sort of presentation that's seen in the children's emergency department in screening and in echo clinic. The kids that are found to have effusion, they're referred to the cardiothoracic surgeon for drainage or TAP. Children with TB, pleural effusion. So pericardial effusion is quite common because of TB, and so is TB pleural effusion. So these children are often referred for underbody drainage. Children with rheumatic heart disease are either, when they're diagnosed, they're put on prophylaxis or medical treatment, and a lot of times they present late when they have heart failure, so they get put on heart failure treatment. We follow them up until 18 years of age. We refer them to the adult clinic where they may or may not get a heart valve surgery or replacement, depending on the assessment. Children with PDAs are referred for PDA ligation or device closure, and lesions that can be corrected locally through open heart surgery, ASDs, VSDs, TAPVR, and valve repair or replacement. And that's by the local team with support from the Open Heart International team. And children with other heart lesions are followed up locally. Overseas referral is only done if the family requests and are able to afford, and that's about 1 to 2 cases in a year. So echocardiography in children. So the heart is looked at in 5 windows. The parasternal long axis view, the parasternal short axis view, and then the apical 4 and 5 chamber view. What I haven't included there is the suprasternal view, and I'll go through each and one of them just to see what we look for in those views. So the subcostal view is a view that's used to assess the abdominal situs in children, and also to look at all 4 chambers of the heart, including the atrial and ventricular septums, the atrioventricular valves, and this is also a view where you can look for pericardial effusion and also the systemic venous return. There are other things you can also look at in this view if you're quite comfortable with doing pediatric echo. Often at times it may not be the great place to view the heart, and so other windows can be used to look at the heart. The parasternal long axis view, this is what would look like in a parasternal long axis view, and I think a lot of you are familiar with that. So you're looking at more the left side of the heart, so the left atrium, mitral valve, left ventricle, aortic valve, septum, and the right ventricle. So pericardial effusion also can be assessed from this view. Rheumatic heart disease can also be assessed from this view, looking at the mitral and aortic valve in the same plane. And I think I'll just go to the, and so in a normal heart, the left atrium, aorta, and the right ventricle should be of more or less the same size. This is just to demonstrate what a parasternal long axis view would look like if you were doing echo. So in parasternal short axis view, you're looking at the heart with the indicator of the probe to the 2 o'clock or the left shoulder position. You'd be able to see the short axis view of the heart at the aortic level, and then fanning downward, you can be able to see the left ventricle at the mitral valve level, at the papillary muscle level, and the apical or the apex of the heart could be seen. And those different levels can be seen depending on how you fan into the left ventricle to look at the heart. The aortic level is where in pediatric echo, a lot of other things could be assessed, like that's where PDA is looked for, or pulmonary valve stenosis. So is the aortic valve in regurgitation, or tricuspid valve regurgitation, and also the atrial septum. Oh, and just going back to that, that all these levels, I think Luis gave a very good talk on rheumatic heart disease in the last Pearl's lecture of the year in December, and he's got some very good notes in there on rheumatic heart disease that may not be covered in this session. So the other view is the apical 4-chamber view and 5-chamber view, where again the 4 chambers of the heart could be assessed. So is the atrioventricular valve, the atrial and ventricular septum. Pericardial effusion also can be assessed from this view. It becomes a 5-chamber view when the aortic valve is brought into view. I think in pediatric echo would normally do this to assess the aortic valve for regurgitation and also to look for higher VSDs. The suprasternal view, I'd like to think of it as looking down from the suprasternal notch to look at the vessels that are returning, blood vessels returning to the heart, and also leaving the heart. So this is sort of like the last, maybe the last of the views in pediatric echo to complete the echo findings, just to make sure that all the vessels going in and leaving the heart are okay and there are no issues with it. So in the first picture, I think that's just trying to show the innominate vein going into the right SVC and the right pulmonary artery. And then if I can just play this, I think this is like to demonstrate the suprasternal view of the aortic arch. In this view, we often look for, or assess the PDA, look for coarctation of the aorta or interrupted aortic arch, and also pulmonary artery branches. So we've just gone through reviews of how would look at the pediatric heart or echocardiography. So now we'll go through some cases of children that we see in the clinic, or the common cases that we see. So we'll start off with this one. This was a 3-year-old that was referred last month because they saw massive globular heart on the chest X-ray. So on presentation to the Children's Emergency Department, the quick heart scan was done that showed massive pericardial effusion in tamponade. Unfortunately, we weren't able to record that initial echo showing the massive effusion in tamponade, but I've got other pictures that I can show you subsequently. So on confirming the diagnosis, the cardiothoracic team were involved in putting in a pericardial drain. And this was the echo sort of taken 5 days after the pericardial drain was done. TB treatment started with steroids. So it showed a very good functioning right ventricle, but with still minimal pericardial effusion. This child actually recovered and went and was discharged to complete the rest of TB treatment at home. Now the next And the next case is also an echo of a child. So most of the children presenting with pericardial effusion, they often present late, and we find them in tamponade. So this is also another apical view of a child that presented with cough, shortness of breath, muffled sounds. So you can see that this black around the heart is this massive pericardial effusion. Let me just play that just so. So if you have a look at that, you can see that the effusion is massive. The right ventricle appears to be collapsing in systoles, or in that would be a sign indicating that this child is in tamponade. So right ventricular collapse in systole. So massive tamponade. So again, this is showing again echo of another child that came in with cough, shortness of breath, and muffled heart sound. So echo done. So the first picture shows the subcostal view of the heart. And just in the still picture, you can see that there is effusion around the heart. The left ventricle is well seen compared to the right ventricle. And again, it's just demonstrating that the right ventricle is collapsing in diastole. So this kid was also in tamponade. That's the same kid's echo. Maybe it's not a better echo because we're not able to show the rest of the right ventricle to demonstrate the collapse. But it just shows also massive pericardial effusion. So this next picture is also another pericardial effusion. It's an attempted apical four-chamber view. So often at times the children that come in with massive pericardial effusion in tamponade are so distressed to lie down. So we attempt to do the echo with them sitting up because that's they're comfortable sitting up than lying down. So I think what I'm trying to show on this scan is just massive pericardial effusion. It was an attempted apical four-chamber view, but we're trying to show massive pericardial effusion with fibrin strands that we often see in TB pericardial effusion. So the flagella-like movement are the fibrin strands. Okay, so those were pictures of kids that presented with pericardial effusion, and all of them sort of in tamponade. So now we're just going to go through some echo pictures of children that we see with rheumatic heart disease. So rheumatic heart disease is also a common presentation to the pediatric echo clinic, and often they're presenting late and in heart failure. Like I said earlier on, Louis gave a great talk on rheumatic heart disease in the Pearls December lecture, and you can watch it on the Pearls YouTube. It is a whole lot of great information on rheumatic heart disease, which may not be covered in this session. Thank you, Louis, for that. So this is an echo of a 12-year-old that was referred to the clinic as well. Maybe the first picture is not a great picture because it is a subcostal view. We could have made the picture a little bit better by making it bigger and looking at all four chambers of the heart. But I think from what we can see, there's some LV dilatation. Maybe the mitral valve is thickened. I think we can see it better on the parasternal long axis view. So the left atrium is dilated in this view, and the anterior mitral valve leaflet has got that typical sort of hockey stick appearance. So in comparing the left atrium, the aorta, and the right ventricle, it's dilated more than the other two. So this is the same patient, but now with color Doppler, just to demonstrate how severe the lesion is and what was there, whether it was mitral stenosis, mitral regurgitation on the color Doppler. So, sorry. So the blue jet that's going back into the left atrium just demonstrate the regurgitation in systole. The same patient, looking at the apical 5 chamber view, were able to demonstrate that she also had aortic regurgitation from the color Doppler with regurgitant jet back into the left atrium left ventricle in diastole. So this patient both had mitral regurgitation and aortic regurgitation. This is another echo of a 12-year-old that was referred during the screening because she had recurrent chest infection and shortness of breath on exertion. She was started on TB treatment because of those presentation. So when we saw this first picture, it shows that she had a very dilated left atrium, maybe thickened mitral valve. And looking at it on the other view, you can see that the tricuspid valve opens better than the mitral valve, which is thickened and sort of tethered. So so that's just basically, shows that she had mitral stenosis, and it shows on a closer look, you can see that the red regurgitant jet indicates that she had mitral stenosis, maybe not so much of mitral regurgitation. Doing assessing the mitral valve gradient and the mitral valve area would tell us how bad the mitral valve stenosis is. So this is also another girl that was seen during screening. You can see that the right ventricle here appears to be more dilated than the left atrium. The tricuspid valve appears to be open, but thickened. The mitral valve doesn't look like it's open. So when we look at it closely, again, tricuspid valve is opening better than the mitral valve, which appears to be stenosed as well, and it's thickened. There is also maybe just deviation of the interatrial septum to the left. And using color Doppler just to check what's really happening at the mitral valve. With color Doppler, it shows that she's got mitral regurgitation, the blue jet back into the left atrium, and mitral stenosis, the red jet that's going into the left ventricle. So on this view, she's got mitral regurgitation and mitral stenosis. Checking tricuspid valve out as well. showed that she had severe tricuspid regurgitation as well. May not be clear, but you can also see there's a bit of jet coming out from where the aortic valve is. So that's also indicative of aortic regurgitation. So she had mitral regurgitation, mitral stenosis, aortic regurgitation, and tricuspid regurgitation. That's just our echo in the parasternal long axis view. Again, just demonstrating the mitral stenosis and mitral regurgitation in the same plane. And so you can also see the aortic regurgitation on that view. Her left atrium is dilated, and that's because of the mitral stenosis. Yes, I think, okay, so that's rheumatic heart disease. And then we also see congenital heart disease as well in the clinic. So this was a 7-year-old that was referred because of a murmur during screening last year. Just from this picture, it shows that the left atrium and left ventricle may be a bit dilated. In this setting, the differentials looking at that echo would be rheumatic heart disease, a VSD, or a PDA. But the clinical findings of listening to the chest pre doing the echo, the murmur characteristics would point to what the most likely diagnosis is before we do the scan. So we looked at all the possible sort of differentials, and then turned out to be a ventricular septal defect that's shown by the left to right shunt in the ventricular septum. Again, another child that was referred because of a murmur during screening. So looking at this echo, again, the left atrium, left ventricle is dilated. Top of the list differentials would be rheumatic heart disease, considering the age, VSD, and a PDA. The murmur characteristics, again, will help differentiate what the most likely lesion is before doing the echo. So he had a VSD, so the ventricular septal defect that's there. And you may see that we had to do a 5-chamber view to assess that properly. And then in the parasternal short axis view, often we look at this in this view to look at higher VSD. So in this view, this is the defect that happens to be a perimembranous VSD with left to right shunting on the echo. Okay, this may not be clear, but what we're trying to show here is that would be the IVC, the liver, as we see, maybe just coming that way, the right atrium, left atrium, and that's supposed to be the atrial septum. So that's looking at the heart from the subcostal view. So this is a female that was referred during the screening to exclude congenital heart disease. And if you look at it, the septum that's here, there's flow across the septum. So there's left to right shunt through the atrial septum. So she has an atrial septal defect, looking at it from the subcostal view. And in the 4-chamber view, that's just demonstrating, again, the defect in the atrial septum in the left to right shunt. maybe a bit of RV dilatation because of volume load on the right side. Okay, another echo of a female, a year, 9 month, referred last month because of recurrent chest infection, failure to thrive, not improving on antibiotics. So the scan shows left atrium, left ventricle dilatation. Considering the age, 1 year, 9 months, top of the list differentials would be PDA, VSD. So that's in the apical 4-chamber view that shows left atrial and left ventricular dilatation. So in the parasternal short axis view, I think if there's no colored Doppler, there is what's often referred to as the 3-finger sign. That's 1, 2, 3. So the first one would be the right pulmonary artery pressure. The middle one would be the right pulmonary artery, left pulmonary artery, and the one towards the side is the PDA. So in the short axis view, which is showing the pulmonary arteries with the PDA, that's the red shed, it's the left to right shunt from the aorta back into the pulmonary artery. Another child seen in the clinic, she was actually put for surgery, but the surgery wasn't done because they ran out of time. So we're still following him up. So on this echo, his left ventricle just looks, shows that he's got left ventricular hypertrophy in the parasternal long axis view. And then looking, so often left ventricular hypertrophy could either mean aortic stenosis or coarctation of the aorta. So looking at the arch of the aorta from the suprasternal view showed as the arch comes this way, it narrows there, and that's where the coarctation is. A normal arch of the aorta should look like nice and patent. So we've just gone through some of the point of care ultrasound scan in pediatric echo clinic. So pediatric echo in children is looked at in summary in 5 views. The subcostal view, looking at the chambers, the atrioventricular valves, atrial and ventricular septum, and pericardial effusion can also be looked at from that view. And like I said earlier on, you can be able to see other things once you're comfortable with doing the echo. It is also used to assess the abdominal situs and the venous return. The 4 and 5 chamber apical view, again, that is used to see all 4 chambers of the heart, the atrioventricular valves, atrial septum, ventricular septum, and the aortic valve as well. And then the parasternal long axis view, looking at the left side of the heart and the right ventricle, and the parasternal short axis view, where you'll be able to see the heart at the aortic level, mitral valve level, and the papillary muscle or the apical level as well. And then the suprasternal view, that's looking at the vessels returning back to the heart or leaving the heart. And often, at times, you can also, apart from seeing the normal vessels, you can see abnormal vessels as well in that view, like in a supracardiac TAPVR, where there may be a vertical vein coming up that way. I think that's it. Thank you all for listening.